Hey, I'm Ellie, and this is Lynn.
Hey!
Last year, I was diagnosed with depression. Lynn was there to see the whole thing go down. You've probably heard the words depression before, but might not know exactly what depression means. Let's say you get some bad news. Hey.
Oh my god. I just saw your boyfriend holding hands with Jenny at the mall. He is so over you.
Things like breakups are painful and might make you feel sad, frustrated, angry, or heartbroken. But trust me, most teens go through that kind of stuff. Depression is something completely different. Check this out. Think of the thermostat in your house or apartment. When the temperature in your house gets too cold, the heat kicks in and brings the temperature back to just right. Your brain works a lot like the thermostat. Let me show ya. Let's say this line is the just right mood. And these two dotted lines are the happy and sad range of emotions that you might feel whenever. Like the thermostat in your house, when your mood goes down, your brain makes changes to bring your mood back up. When your mood goes up, your brain makes changes to bring your mood back down to that just right level. When I was depressed, it was like the thermostat in my brain broke. My mood started going down, and I got totally stuck, like at the super low level. That's when depression came into my life. When I was depressed, there were some really obvious signs that something was wrong. My sleep changed. I wanted to sleep all the time. I had no energy. Even brushing my teeth felt overwhelming. That sounds stupid, but that's how I felt. I lost interest in all the things I used to like. It seemed like nothing made me happy or excited anymore.
Don't answer the phone. No one wants to talk to you. Look at yourself. Who'd want to be around you?
I had lots of sad thoughts and feelings. It was like my brain kept saying things to me that I would never have thought before.
Ellie, I care about you. Things are gonna get better. I promise. You're just having a hard time right now.
Am I always going to be like this? I just feel so sad.
You're my best friend, and I know you're gonna get through this. I think you should talk to someone and try to get some help.
Just leave me alone. I felt like I was on an elevator going down, and I couldn't get off. I started to think that I'd be better to die than to keep feeling so sad. That scared me. I remembered what my friend Lynn said, and I decided to get help. I went to see a therapist. The therapist told me that the thoughts of sadness and hopelessness and suicide were my depression talking. My therapist said that as my mood went back up, depression would be forced to leave me alone. The other thing was to take the meds my doctor prescribed me to help my brain work the way it did before I was depressed. Having Lynn's support made a huge difference. After taking the meds for a while and talking to my therapist, I really started to feel better. Life is worth living again.
I'm just happy you're back to your old self. I told you you'd feel better.
All right, we've got some serious texting to do, so TTYL.
Depressive disorder, also known as clinical depression, major depression, unipolar depression, or unipolar disorder, is a mental disorder characterized by a pervasive and persistent low mood that is accompanied by low self-esteem and by a loss of interest or pleasure in normally enjoyable activities. The term depression is used in a number of different ways. The term depression is used in a number of different ways. It's often used to mean this syndrome, but may refer to other mood disorders or simple to a low mood. Major depressive disorder is a disabling condition that adversely affects a person's family, work or school life, sleeping and eating habits, and general health. In the United States, around 3.4% of people with major depression commit suicide, and up to 60% of people who commit suicide had a depression or another mood disorder. The diagnosis of major depressive disorder is based on the patient's self-reported experiences, behavior reported by relatives or friends, and a mental status examination. There is no laboratory test for major depression, although physicians generally request tests for physical conditions that may cause similar symptoms. The most common time of onset is between the ages of 20 and 30 years, with a later peak between 30 and 40 years.
The term depression is a very general term. There is a lot of specific terminology under the term of depression. Understanding the types of depression is very important. For example, some patients suffering from 2 days of depressive or mild depressive symptoms happen every few days, 2 days it happens. We call this as a minor recurrent depressive episodes. Understanding the very specific type of depression and the terminology, different terminology is very important, because this type of depression is not indicated to be treated by antidepressant. Other modalities maybe will be very helpful. Sometimes we could use the PRA medications to be used, some form of anxiolytic, and this type of depression is more easy, especially when it happens 2 days every 1 or 2 months. Why to expose the patient to use these type of antidepressants, etc., with its side effects sometimes in some patients, and instead of using 1 or 2 days, some good medication of anxiolytic. Other term of depression, sometimes depression happens after schizophrenia, post-schizophrenic depression. Sometimes depression come alone or come as part of other psychiatric disorder. For example, bipolar disorder, depression is an episode of bipolar disorder that come alone. Sometimes it's secondary to organic causes, or sometimes could happen as a comorbidity with organic disorders. For example, Parkinsonism. 50% of Parkinsonian patients and malignancy also, 50% malignant patients will have depression as a comorbidity of that disorder.
Depression is a very common disorder amongst adult population and children as well, though I'll just talk about adults today. Statistics generally show you that about 20% of the adult population at any given time can experience some kind of depressive disorder, and this is a statistic that's repeated globally, so it's a very common problem amongst adults.
Depressive disorder are disorder characterized by mood instability and mood dysphoria and loss of interest.
Premenstrual dysphoric disorder. If we can focus or make a wide range of view to depression episode, we can find that the females suffering from premenstrual syndrome, or what we call the disturbance of mood before and after period during every single month. This is a biological functions, and this is actually is normal. But if it is continue and make disturbance in her lifestyle and make a disturbance in her relationship with her partner or with her children or with her people around her, then it is started to make an impairment in her occupational and impairment in her social functional, and then it started to be a disease or an illness of her mood, and then she need a medication to enhance her mood before or maybe after premenstrual or after the period.
Having a major depressive episode usually exhibits a very low mood, which pervades all aspects of life, and inability to experience pleasure in activities that were formerly enjoyed. Depressed people may be preoccupied with or ruminate over thoughts and feelings of worthlessness, inappropriate guilt or regret, helplessness, hopelessness, and self-hatred. In severe cases, depressed people may have symptoms of psychosis. These symptoms include delusions or, less commonly, hallucinations, usually unpleasant. Other symptoms of depression include poor concentration and memory, withdrawal from social situations and activities, reduced sex drive, and thoughts of death or suicide. Insomnia is common among the depressed. In the typical pattern, a person wakes very early and cannot get back to sleep. Insomnia affects at least 80% of depressed people. Hypersomnia or oversleeping can also happen. A depressed person may report multiple physical symptoms such as headaches or digestive problems. Physical complaints are the most common presenting problem in developing countries, according to the World Health Organization's criteria for depression. Appetite often decreases with resulting weight loss, although increased appetite and weight gain occasionally occur. Family and friends may notice that the person's behavior is agitated. Older depressed people may have cognitive symptoms of recent onset, such as forgetfulness and a more noticeable slowing of movements. Depression often coexists with physical disorders common among the elderly, other cardiovascular diseases, Parkinson's disease, and chronic obstructive pulmonary disease. Depressed children may often display an irritable mood rather than a depressed mood and show varying symptoms depending on age and situation. Most lose interest in school and show a decline in academic performance.
Symptoms of depression should be present for at least 2 weeks, and symptoms of depression should cause significant impairment in the client's lives. It should include three or more core symptoms of anxiety. It may include depressed mood, anhedonia, and such depressed mood or anhedonia, one of them should be present when speaking about diagnostic features for depressive disorder. Other features that should be present, it includes the impairment in their sleeping pattern, the impairment in their appetite, the loss of their ability to concentrate, the loss of their ability to perform in certain situations, as well as increase in their impairment. Usually there is thoughts of suicide associated with depressive disorder.
Characterized by errors, loss of concentration, and inability to do any activities, to laugh, crying, loss of concentration, and fatigue, and hypersomnia or insomnia, hyperphagia or loss of appetite. Many criteria or many symptoms of this disorder collect to produce depressive disorder.
Diagnose a depressive episode, and hence the major depressive disorder. There are certain diagnostic criteria and features that the psychiatrist should look at in order to diagnose a depressive episode. First of all, we know that the depressive episode is usually affects the mood, and the mood is usually low or depressed. However, all of us might have a day or two where our mood is down or low because of normal life stressors. However, in the major depressive disorder or clear depressive episode, the mood should be low for a longer period of time, usually for a minimum of 2 weeks, and usually every day. So this is one of the major area in which we should look at and explore, which is the duration. There are, of course, other clinical features that might help aid the diagnosis of a depressive episode. For example, we find that the individual might have loss of interest. When he used to go out and socialize with others, now he's more confined to his room, he doesn't want to go out. Other symptoms might include disturbance in sleep, in which the individual starts to have difficulty falling asleep, which we call insomnia. Also changes in appetite and sometimes even weight. The individual might have a strong drop, a big drop in weight within a short period of time. Other symptoms, of course, are feelings of negativity in general, that is, feeling of loss of esteem, feeling of worthlessness, and sometimes even feeling of guilt. And in even severe cases of depression, we might find individuals having a feeling of hopelessness and even death wishes. They wish that they die and leave this life so they can feel rested. and escape this dark and doom associated with depression. And in certain individuals and with severe cases of depression, we should always screen for suicide. Some of them might actually start having suicide thoughts and might even try to attempt suicide, either by swallowing an overdose of certain medication, or if they have certain weapons or dangerous object in the house, they might use it to harm themselves and end their lives.
Associated features supporting diagnosis. We can find that there is some sort of other features or other signs and symptoms or other factors which can support the diagnosis of depressive or dysregulation mood disorder, such as the feeling of sadness and the feeling of helplessness and hopelessness in patients who are suffering from depressive disorders. Another and very important thing that there is a percentage between 2% to 5% most common in depressive dysregulation disorder.
Diagnostic criteria. Usually if you want to diagnose delusional disorder in the patient, usually you must have at least three criteria. This is the main criteria to diagnose delusional disorder. First criteria, the patient will present it with non-bizarre delusion. Non-bizarre delusion means that there is what we call abnormal belief or thinking, but it can occur in real life. The presented patient might suffer from paranoid ideation, which can occur in real life. He will believe that, or he is thinking that he is under influence of magic, and it is in non-bizarre way. If you ask the patient to explain it, he will explain it in systematized way without any amazing from our side. So there is non-bizarre delusion for more than 1 month. Second criteria, the affected person will present or will show and demonstrate accepted level of function.
There is two kinds of differential diagnosis in depressive disorder. One important and significant of them, that the destructive mood and the dysregulation disorder and the oppositional disorder. Another thing, major depressive disorder and anxiety disorders, and patients at the early developmental phases who are suffering from attention deficit hyperactivity disorder and anxiety disorder may suffering from some sort of depressive disorders, especially at moderate adulthood.
In terms of symptoms, and be thinking that you might be feeling depressed, is you would have feelings of overwhelming sadness, you may have a lot of crying spells, you may have a disturbance in your sleep pattern, you may sleep too much, too little, you may find that your eating habits, your appetite is changing. Like the sleep, you might find that you're eating too much, you might be eating too little. You may even get severe symptoms like feeling suicidal, wanting to self-harm, feeling that life is hopeless and you can't go on.
These interactive models have gained empirical support. For example, researchers in New Zealand took a prospective approach to studying depression by documenting over time how depression emerged among an initially normal cohort of people. The researchers concluded that variation among the serotonin transporter 5-HTT gene affects the chances that people who have dealt with very stressful life events will go on to experience depression. In addition, a Swedish study estimated the heritability of depression, the degree to which individual differences in occurrence are associated with genetic differences, to be around 40% for women and 30% for men. And evolutionary psychologists have proposed that the genetic basis for depression lies deep in the history of naturally selected adaptations. A substance-induced mood disorder resembling major depression has been causally linked to long-term drug use or drug abuse.
It has been found that the major depressive disorder is higher in females to males. The ratio might reach up to 2 to 1. So there is a clear gender differences in the major depressive disorder. It seems that the females are more prone to the developing a depressive disorder. And the reason behind that is still under investigation. There are several theories and research is still ongoing to find the reason behind that the females are more prone to depression than males. One of these theories is that the hormonal disturbances and changes in the females is quite apparent, and that the females, because they go through pregnancy and deliveries, they have major hormonal changes which might have an effect on development of depressive disorder. So this might have could be one of the reasons in why the depressive episode is actually higher in the females than in the males.
The causes of depression are many. There are biological features going on, so there's a change in brain chemistry, though they don't know whether that's to do with the cause or something that happens after you've had a stressful life situation. Typically what happens is you're having some kind of stress in your everyday life. It could be due to a relationship breakup, it could be due to a bereavement, it could be due to work pressures and stress. There are a number of reasons why you might find that you're getting depressed. It could even be to do with things that have gone on in your childhood, memories of your childhood and the way you were brought up, coming back to the surface again as an adult.
Each psychiatrist should be able to have quick and rapid assessment for a suicide risk in every patient with a depressive episode. Suicide and a feeling of hopelessness, worthlessness, death wishes and suicide are sometimes there in patient with depression, and we should assess for the risk of these having suicide risks to prevent the patient from harming himself and even committing suicide. So what a psychiatrist should do usually is that he screens for certain factors. For example, we should ask the patient, or if the family know, if the patient has a continuous thought wanting to end his life. If this thought is always there with him for a long period of time and for several days, in contrast to an individual who has only an impulsive feeling of wanting to kill himself at a certain point because of a stressor, is different from that who has a continuous suicide thought. Other risks that we should look at is are there any previous suicide attempts from the patient? The presence of previous attempts suicide in the past might indicate that the patient might have another suicidal attempt, so this will increase the risk of his suicide, of him attempting suicide. Other risk factors is the severity of depressive symptoms. Are they there for a longer period of time? Does he have more than one symptom of a depressive disorder? And does it affect his function markedly? Also, other risk factors for suicide can include the use of substances, illegal substances, using alcohol or stimulants, or even hash or cannabinoids can increase the risk of suicide. And also the presence of any medical problems. If the patient has diabetes or any other medical problems, might increase the risk of his suicide.
Treatments. The three most common clinical treatments for depression are psychotherapy, medication, and electroconvulsive therapy. Psychotherapy is the treatment of choice for people under 18. Care is usually given on the outpatient basis, whereas treatment in an inpatient unit is considered if there is a significant risk to self or others. Other treatments include light therapy, sleep deprivation, physical exercise, stopping smoking, mindfulness meditation, and music therapy. In general, the type of treatment is less important than involvement in a treatment program. Psychotherapy can be delivered to individuals, groups, or families by mental health professionals, including psychotherapists, psychiatrists, psychologists, clinical social workers, counselors, and suitably trained psychiatric nurses. With more complex and chronic forms of depression, a combination of medication and psychotherapy may be used. A 2012 review found psychotherapy to be better than no treatment, but not other treatments. Antidepressants is none to minimal in those with mild or moderate depression, but significant in those with very severe disease. Combining psychotherapy and antidepressants may provide a slight advantage, but antidepressants alone or psychotherapy alone are not significantly different from other treatment. The effects of antidepressants are somewhat superior to those of psychotherapy, especially in cases of chronic major depression, although in short-term trials, more patients, especially those with less serious forms of depression, sees medication than sees psychotherapy. Most likely due to adverse effects from the medication and to people's preferences for psychological therapies over pharmacological treatments. To find the most effective antidepressant medication with minimal side effects, the dosages can be adjusted, and if necessary, combination of different classes of antidepressants can be tried. Selective serotonin reuptake inhibitors, SSRIs, are the primary medications prescribed owing to their relatively mild side effects and because they are less toxic in overdose than other antidepressants. Antidepressants appear to have only slight benefit in children. There is also insufficient evidence to determine effectiveness in those with depression complicated by dementia. Electroconvulsive therapy, ECT, is a procedure whereby pulses of electricity are sent through the brain via 2 electrodes, usually one on each temple, to induce a seizure while the person is under a brief period of general anesthesia. Hospital psychiatrists may recommend ECT for cases of severe major depression that have not responded to antidepressant medication, or less often psychotherapy or supportive interventions.
To use medication or not to use medication is another very good question to be used, to be discussed. Is it suitable to this type of depression and medication or not? And what type of medication? And the issue of prophylaxis is another issue, is very important to discuss and think about it in dealing with depression.
Drug treatment. A lot of patients who are suffering from mood disturbance make what we call self-medication in psychiatry, that they know or listen about one of their friends that there is a good medication to enhance the mood, and then to go to the pharmacist and ask it for this medication without any documentations or without any description from the doctor or from the medicine. And this is a very wrong way to treat depression, by the way, because there is some sort of antidepressant make substance or make some sort of addiction or dependence, so the patient take it and then started to depend over it. So it's most important thing when you're suffering from distress in your mood or disturbance in your mood or feeling of frustration or feeling of sadness or disturbance even in your thinking and started to be isolated or feeling of social withdrawal, you have to go to the psychiatry for make an assessment.
Treatment goes, medical treatment with the psychiatrist would include medication, typically what they call SSRIs, and you can take that with the ongoing guidance of the psychiatrist. You need to make sure you're taking the right dose, you need to make sure that you're taking it regularly, you need to make sure that you can report any side effects that might be happening for you. Psychological treatment for depression would focus on you changing your thinking patterns typically. Within psychology, these days the popular mode of treatment for depression is what they call CBT, cognitive behavioral therapy, and that is focusing on changing the way you are thinking. It's trying to focus on some of the automatic thoughts that you have that make you feel depressed. So typical thoughts you have about feeling that you're not very good at something, that people don't like you, that you feel you've got no hope with the future, you feel there is no future, or you're not good at things. So very negative thoughts about yourself and the future and your position in it. And what psychological therapy will do is help you unpack these thoughts and make you think of alternative ways, instead of just focusing on those negative automatic thoughts, trying to be kinder to yourself, trying to be more motivating to yourself, and find other ways of viewing situations.